Hello, welcome. Thank you for joining us. We are here today joining the CLDF to discuss navigating non-adherence and compliance in Wilson disease. My name is Amanda Cheung. I am a transplant hepatologist at Northwestern University and the co-director of the Wilson Disease Center of Excellence at our center. And I'm joined here by Dr. Hedera.
Good afternoon. Thanks for joining us. My name is Peter Hedera. I'm an adult neurologist and also trained and board certified in medical genetics. I've been working in the Wilson disease area for the last many years. I specialize not only in neurological presentation of Wilson disease, but also overall treatment and new decoupling strategies for patients with the Wilson's disease. I work at the University of Louisville in Louisville, Kentucky.
Awesome. So maybe I'll pose the first question or the first topic of discussion. Dr. Hedera, as a neurologist, perhaps you can discuss with us the neurologic trajectory of Wilson disease and how it affects a patient's quality of life and their daily functioning.
Certainly. So what's unique about Wilson disease, as the old historical term hepatolenticular degeneration would reflect, it is kind of a combination of neurological and hepatologic symptoms. There can be additional psychiatric or others, but neurological symptoms are present in about 40 to 50% of patients, and they are very pleiotropic. They're very heterogeneous, and can also mimic other conditions. But when you think about four major type of symptoms and signs in neurologically active Wilson's disease, it is tremor, dystonia, ataxia, and parkinsonism. So again, and the burden of disease, of course, is always affected by what some of the symptoms and signs are most prevalent. Probably the most disabling is dystonia, because in Wilson's disease is so-called secondary dystonia. And this patient may suffer not only from painful contractions, but also it can affect speech and swallowing. Tremor, of course, can be very disabling. There is this so-called wing beating tremor, which is typical, but of course can be present in any different type of tremors as well. But it's mostly action tremors when these patients try to perform even mundane daily tasks like grooming, eating, drinking. They can be very disabled. And Parkinsonism, of course, is similar to Parkinson's, of course, is a different cause, but would be slowness and stiffness of movement. So degree of severity really varies from mild tremor, which may be slightly limiting, to really severe disability. I have patients who are essentially wheelchair dependent, mute, have to have a PEG tube, feeding tube. And of course, this is a lifelong therapy. And if these symptoms are diagnosed and this condition is diagnosed late, they may be irreversible. So that can really create long-term burden for the quality of life of these patients. And again, some of them may have a fantastic, improvement to nearly normal full recovery, but some patients may have a quite sustained long-term disabling symptoms. And Dr. Cheung, so tell us more about hepatic symptoms which these patients may experience and how it may affect their quality of life.
Sure. So I think from a liver standpoint, the difference between the hepatic versus the neurologic is most patients, even with significant hepatic disease due to Wilson disease, don't actually have symptoms. So there's a very wide variety of presentations, of course. So we sometimes think of Wilson disease from a hepatic standpoint being a quote unquote silent disease. So for instance, patients may just show up for a routine clinical visit, have some blood work taken, and their liver tests are abnormal, or their liver enzymes are elevated. One of the mimickers of Wilson disease is that it can look like steatosis or fatty liver disease, which is now becoming increasingly prevalent in the entire world, including in the United States, for other reasons. And sometimes those patients will be misdiagnosed as simply having fatty liver disease from other causes, when in fact it was Wilson disease in the background. Now, if there is progression of the Wilson disease in the liver and they're starting to develop fibrosis or scarring in the liver, even early scarring doesn't cause symptoms. But once they've progressed to cirrhosis, or the most advanced form of fibrosis or scarring, then that's when they start to have all the typical symptoms of cirrhosis, which are the same as other causes of cirrhosis. So, for instance, they may develop ascites, which is fluid in the belly that needs to be drained. They may develop encephalopathy, which is a specifically hepatic encephalopathy, which is confusion due to the impairment of the liver to clear toxins. Then the most severe presentation of Wilson disease, which is the least common but certainly does occur, is acute liver failure, where the patient is presumably completely normal, has no idea they have liver disease, and then they walk in the door, or maybe they're brought in and their liver is no longer functioning and they have to go on to receive a liver transplant. So in those cases, of course, post-liver transplants, there's all the typical symptoms and that occur post-transplant, which isn't necessarily directly related to Wilson disease. So I think, we have a good idea of, the differences between hepatic and neurologic trajectories. Dr. Hedera, can you, from your standpoint in your clinical practice, what are some of the barriers that you've identified in patients that is keeping them from being adherent to their Wilson disease treatment plan?
Yeah, I would also point out, as Dr. Cheung said, that the treatment is really lifelong unless the patient has a liver transplant, which of course would be so curable, in terms of Wilson disease. But again, what is very challenging about treatment of Wilson disease that it is really lifelong therapy. And some of these patients are, either children or, younger adults. So when you think about, decades of treatment, so I think that adherence and non-compliance is really a significant challenge. When we think about treatment for Wilson disease, and here I would really lump liver and neurological presentation together because it's very similar. There's this acute or induction phase, and which then transitions to more maintenance therapy, which again, as I said before, needs to be lifelong. So in the acute stage of treatment, we use chelating agents. So we have two approved medications, penicillamine and trientine. When I say trientine, I'm also referring to both salts of trientine, dihydro and tetrahydrotrientine. And of course, for the maintenance, we can use either these chelating agents in lower dosing or zinc, which are zinc salts, which can be used more because they take longer to work, so they can be more suitable for maintenance therapy, even though they're probably less suitable for liver presentation patients, because these patients still may have some, escape of disease control. So when you think about major barriers and challenges, that typically the dosing is 3 times a day. Furthermore, so both it's true for trientine and which is again dihydrotrientine and penicillamine. The other very challenging factor that has to be separated, from food about 2 hours. So especially so they got the medications, one needs to really plan the therapies in terms of food intake, and also some of these potential side effects, especially in the early stage of the treatment of the disease, may be nausea. So that can be very challenging. The zinc treatment, which could be mostly maintenance, again, is also 3 times a day. Similarly, needs to be separated from food 2 hours. And especially when we transition, so when I use zinc as a maintenance therapy, let's say from trientine, there also has to be overlapping about bridging, because again, as I said, zinc takes about 3 months to work because it works differently. It's not a chelating agent. It's a medication which induces metallothioneins in a small intestine, and it would block the absorption of copper from food, and then would induce negative copper balance. Because again, overall idea of the treatment is to induce negative copper balance, so decopper these patients and then keep them in the negative copper balance throughout the years. What is probably specific for neurological presentation would be the dysphagia. I mentioned how these patients would have difficulty swallowing, so that's a sort of additional property specific for neurological patients. But I think that this is sort of, these challenges are very similar. And as I said, this is a really lifelong therapy. Actually, I have a few patients who have even medical background who were really decoupled very successfully, were really stable, minimal symptoms or any, and they stopped the medication. So I think really talking to patients about importance of adherence, of course, we can do monitoring of these patients with a 24-hour copper urine. That's my strategy. But it's really kind of lifelong also on our part as a healthcare providers to make sure the patient understands the treatment importance, but also that we address side effects, because there are some new strategies, some of the new medication which can help him, may have a less than 3 times a day dosing, which again, we know that adherence with a three times a dosing, is less ideal than, let's say, twice a day or once a day. So this would be sort of my take, my look at this adherence. And so, Dr. Cheung, what is your take? Do you see similar challenges in your patients with a hepatic presentation?
Yeah, I think their overarching principle of medication adherence is probably the same, regardless of whether they have hepatic or neurologic manifestations, or maybe both. Perhaps maybe one of the difficulties is sometimes in the beginning when patients are first diagnosed, almost convincing them they have a disease. So I think maybe for the patients who have neurologic presentations, perhaps it's easier because they have symptoms and they're manifesting with something that is bothering them and is affecting their quality of life. Whereas from a hepatic standpoint, because the majority of these patients don't have symptoms and you're just telling them maybe their liver enzymes are elevated, the motivation to take a medication every single day that is a little bit cumbersome, to be honest, compared to what they used to do, which was just eat when they wanted and do, not have to think about timing. So I think one of the barriers for for the patients who do not have neurologic symptoms but only have hepatic manifestations is, quite frankly, convincing them that they need to take the medication. And not only that, but also that the medication needs to be for the rest of their life. So the majority of our patients are diagnosed at a relatively young age, whether it's childhood or early 20s or 30s, less commonly beyond that. And knowing that they're going to have to take something for the rest of their life sometimes can be a little bit of a challenge to convince them. One of the barriers that you brought up was the dosing. So when especially with the patients that I only take care of adults. So when the patients transition over from the pediatric side, on the pediatric side, of course, usually their parents or caregivers are telling them exactly what to do. By the time they come meet me in clinic, usually they're starting to become independent. Maybe they've gone off to college or they've at least moved out from under their parents. And so that's when we often see a major drop-off in adherence to medication. Other things that I don't know if you've mentioned already, I can't remember, is the cost issue. So unfortunately, at least in the United States, there's still a lot of cost issues associated with these medications, primarily the trientine and the penicillamine, where perhaps it's covered by the insurance, but there'll still be a very high copay. So that's definitely, and then without insurance completely, it's almost impossible to get these medications for the patients. And then the last thing would just be about diet, which you already, commented on, but the changes in the diet in somebody who is diagnosed at an older age, actually, because then they have to start avoiding certain foods that are known to be high in copper. And then the thing that we mentioned before, which was this timing. I think we always battle in clinic with how do we help these patients with their compliance and their adherence. So do you have any pearls to share with us on things that have been successful with your patients?
No, it's a very similar challenge, and I also basically, I see a lot of college students. I agree that the last thing they want to really is to plan their meals and medications. So we have very similar challenges. Of course, one thing is that we can monitor these patients. We didn't talk about monitoring, but one way we usually use 24-hour urine or sometimes NCC copper, which NCC stands for non-ceruloplasmin copper, but 24-hour copper excretion can be used for monitoring. So we can really detect non-compliance even objectively. If the patient is on zinc, which will be kind of probably more typical for neurologically affected patients, we can also directly measure zinc in urine. So we have also some objective findings in urine monitoring and neurological examination or liver enzyme test to see that there are really compliant, but really emphasizing this, and especially as you said, when they feel better, when we really reverse, if those patients we are able to reverse the burden of neurological disease, they feel normal. And again, so they just kind of really don't want to think about medication. So I don't have any sort of magic bullet. I think that that again, it's really just really discussing. So one thing is actually looking at a medication which can be maybe used less than 3 times a day. So one thing is I will also include about dihydrotrientine specifically that has to be refrigerated. Most of them have to be refrigerated. So interestingly enough, I have a patients who walk with a small cooler sometimes, and it's not their lunch, it's their medication. So tetrahydrotrientine, Courier was recently approved about a year or so. And again, it has 2 advantages. It can be twice a day, and they are even looking at a potentially once a day dosing, which could be quite important for both, adherence, but also the relation with the food, and also doesn't have to be refrigerated. But and also, actually, I absolutely agree with the cost issue, because that's also very important. We want to make sure that sometimes patients try to really ration their medication. So again, that's why monitoring of these patients usually I use 24-hour urine is so useful, but I think we share sort of similar challenges, whether it would be neurologically or hepatologically affected patients. Do you have any additional strategies, Dr. Cheung, or any other insights into how to manage this problem?
Yeah, I think you hit all the major points. The biggest thing really is making sure the patients feel like they are part of the decision making. And if you do that, then perhaps there's more motivation. And I think, especially for the new diagnoses, this can be very overwhelming to them all of a sudden, to learn that they have a genetic inherited disease that is not going away unless they get a transplant, of course. So really working on shared decision making, and when they're first learning about their disease process, making sure that they understand why they need the medication. I found that being part of a multidisciplinary clinic has been extremely helpful, because we all essentially are saying the same things, but it's coming out in a different way from each clinician that sees them. We do have a psychiatrist that works with us as well, which is really important, because we haven't touched on this, but there are psychiatric manifestations of Wilson disease. And of course, if somebody has concomitant depression or anxiety, that obviously can affect their adherence. There are some pretty good patient assistant programs out there to help with cost. Not always available to everybody, but then also some pharmacy models where the pharmacy is actually very involved in the patient and helping the patient, reminding the patient that they're due for a refill. And we on the provider side actually even get feedback from the pharmacy if the patient is reporting back that they don't need a refill yet, when we know that we've sent the prescription on a certain date and they're definitely due a month later, but they're reporting they still have half the meds left over. That obviously implies that they are not taking it the way that we think they're supposed to be taking it. So that definitely has been helpful for us as well. And then also having an integrated social worker in our clinic has been helpful too, because our social worker can help with screening for anything at home that may be barriers, whether it's financial things or some, interrelational things with whoever is living in their home with them. But overall, I think the most important thing is just making sure that the patients feel like they have autonomy, but that they understand that this is a chronic disease that is going to impact them for the rest of their lives. Are there any other stakeholders that you think are important that weren't already mentioned, or any kind of last words on this topic?
No, I don't think so. Again, also, I think that even though we are still in the process of trying to get a designation of center of excellence, but I think the multidisciplinary approach is very, very important. We also try to kind of practice, the shared decision making. And I'm glad you actually mentioned specialty pharmacies. Let's say Panther for Couvrier is one example. It's a single specialty pharmacy, so there's only single source, and also they can provide us exactly with the updates if the patient, also both the patients that they need to refill and to us if they don't refill. So that's actually very nice, useful too. But I think we covered it quite comprehensively. I believe that again, there are still remaining challenges. Hopefully we'll have some medication which will have maybe less frequent dosing, but still doesn't sort of address the, cost issue and again, long-term treatment, because again, there's maybe gene therapy coming, which may provide some respite, so to speak, from standard of care. But again, that idea that this is really lifelong. I have patients who really do it as a second nature, that they are fantastically compliant. And we have patients who really we need to struggle. They struggle with that, and we need to really try to really reinforce that importance to really try to keep the disease under good control. Because again, we are talking about decades of their lives unless there will be additional treatments available. But I think that we covered it quite comprehensively, I believe.
Absolutely. Well, thank you so much for our listeners and our viewers for joining us on this topic of navigating non-adherence and compliance in Wilson disease. And we certainly enjoyed having a chat. Thanks, Dr. Hedera.
Thank you. It was nice to talking to you. And again, thanks for joining us as well.